Hello students, we will continue discussing about the sensory system. Until now we have discussed synapse, various characteristics of the synapse, then neurotransmitters which are released from the presynaptic membrane and will act on the postsynaptic membrane and will cause generation of action potential. Then we have discussed touch and various modalities of touch like fine touch, crude touch, pressure, etc. etc. Then the receptors which are responsible for these modalities like free nerve endings, Merkel's disc, Pacinius corpuscle, Meissner's corpuscle, etc. etc. Then the pathway which is responsible for these modalities, that is dorsal column pathway. Okay, so that is all that we have discussed until now. Now next we will discuss about the pain. Now pain is very important sense, as you know, so we'll discuss in slightly detail. Okay, so let's start pain. Okay, so let's take introduction first. First of all, definition of the pain. It is defined by the International Association for the Study of Pain, IASP, as an unpleasant sensory and emotional experience associated with the actual or potential tissue damage, or described in terms of such a damage. In simple terms, it is an experience which is unpleasant and is associated with the tissue damage. Now another term, which is known as nociception, is defined as an unconscious activity induced by harmful stimulus applied to the sense receptors. So if this harmful stimulus is applied to sense receptor may induce some unconscious activity, then it is known as nociception. So it is slightly different from the pain. Okay, so that's how pain is protective mechanism. Now I will just give you one example. Pain occurs whenever any tissue are being damaged, so it will cause individual to react to remove the pain stimulus. For example, even simple activities such as sitting for a long period of time on ischias can cause tissue destruction because of the lack of blood flow to the skin, where it is compressed by the weight of the body. When the skin becomes painful as a result of the ischemia, the person normally shifts body's weight subconsciously. So subconsciously this pain will give the warning to the brain that something harmful is occurring to the body. So brain will react and will remove this painful stimuli, or will just move our body from such a harmful situations subconsciously or consciously. So pain is basically a warning to the brain that something harmful is occurring to the body. Okay, so that's why it is protective mechanism. Okay, so now we will discuss about the receptors which are responsible for the generation of pain sensation, which are free nerve endings. Okay, so they are widespread in the superficial layers of the skin as well as in the certain internal tissues such as periosseum, arterial walls, joint surfaces, and the fox and tentorium in the cranial vault. Most of the other deep tissues are only sparsely supplied with the pain endings. Nevertheless, any widespread tissue damage can summate to cause slow chronic aching type of pain. Okay, now there are various types of stimuli which can excite the pain receptors. Mainly there are three types of stimuli which will excite this pain: mechanical, thermal, and chemical. Okay, so now extreme mechanical like pressure will generate pain. Extreme thermal changes, cold or heat, may generate pain, and certain chemicals like bradykinin, serotonin, histamine, potassium ions, acids, acetylcholine, proteolytic enzymes may generate pain. Okay, so now how this pain has been generated by tissue damage. Whenever there is a damage to a tissue, it will cause release of certain chemicals when the cell is damaged, these chemicals which are present inside the cell will get released. So these chemicals will cause pain, generation of pain. So mostly tissue damage will cause pain by chemical stimuli. The important chemical which is responsible for this is bradykinin. Apart from that, certain other chemicals are also responsible for that, like potassium ion concentration and proteolytic enzymes, which are more actually inside the cell. So when the cell is damaged or tissue is damaged, this potassium ions, proteolytic enzymes will get released and will cause pain by directly attack the nerve endings. Okay, now apart from the tissue damage, tissue ischemia also will cause generation of pain. Now how it will cause pain? Now in tissue ischemia there will be no tissue damage, but because of the ischemia means devoid of or lack of blood flow. So blood flow is not occurring, so there will be a lack of oxygen. So tissue has to use anaerobic metabolism, which is metabolism without oxygen. So because of this consequence of anaerobic metabolism, there will be a generation of large amount of lactic acids, and because of devoid of blood flow, this lactic acid will not washed out and will get accumulated inside the tissues. Now this lactic acid will cause pain by chemically stimulating the pain receptors. Okay, so that's how tissue ischemia also cause generation of pain. Now after that, muscle spasm may cause pain. Muscle spasm will cause generation of pain by two mechanisms. One is direct, another one is indirect. Directly, muscle spasm will cause stimulation of the mechanosensitive pain receptors. So mechanically it will stimulate the pain receptors and it will cause generation of pain. Another route, indirectly also it will cause generation of pain. Indirectly it will just compress the blood vessels which are passing through the muscles, so the areas which are supplied by this blood vessel will not get blood flow. So there will be a generation of ischemia in those areas, and as we have discussed, tissue ischemia also will cause pain. So muscle spasm will cause pain by two mechanisms: directly by stimulating mechanosensitive pain receptors and indirectly by generating ischemia. Okay, now these receptors will get stimulated by different mechanisms. Mostly they are stimulated by either opening or closing of channels, or activation by some enzymes, or activation of some transcription process. So let's discuss some of them. First is TRP, that is transient receptor potential family. These are the channels which cause the activation of receptors. One of them is TRPV1, transient receptor potential vanilloids. TRPV1 will get activated by intense heat, acids and chemicals. Another example is TRPA1, that is transient receptor potential ankyrin 1. It will get stimulated by mechanical, cold and chemical stimuli. Next is acid sensing ion channels. As the name suggests, it will cause activation of the pain by some changes in pH. Then purinergic receptors. This will get stimulated by mechanical stimuli. The examples of purinergic receptors are P2X, P2Y, etc. The last one is tyrosine receptor kinase A. It will get stimulated when tissue has been damaged. So these are the various types of receptors based on the different mechanism of their activation. Now adaptation. We have discussed that in vision, in hearing, other general senses like touch, all the receptors will get adapted after some time. So after some time you will not receive, your brain will not receive any stimulation. But in case of this pain receptors will not adapt or adapt very little. which is in contrast of other senses. Because see, pain is very important one. So when there is a pain, that means there is some tissue damage, so it should not adapt. So brain constantly will get stimulated until pain has been removed. So until pain is there, you will get stimulation of the pain. So adaptation of the pain is very little or not at all. Okay, so next we will discuss about the types of the pain. Now pain has been classified into two major types: fast pain and slow pain. Fast pain is known as fast pain because it will be felt within about 0.1 second after pain stimulus is applied, whereas slow pain begins only after 1 second or more and then increases slowly over many seconds and sometimes even minutes. So that's why it is known as slow pain. Now fast pain is also described by many alternative names such as sharp pain, acute pain, electric pain, etc, etc. And slow pain is known as burning pain, chronic pain, aching pain, nauseous pain, etc, etc. Now fast pain is mostly felt when skin is subjected to damage that is superficial. So fast pain is not felt mostly in most deeper tissues of the body. Mostly it is superficial, while slow pain is felt by the damage of superficial tissue as well as deep tissue, both. Now some examples of the fast pain. Fast pain is felt when the skin is cut with the knife, when there is a needle is stuck into the skin, then when skin is acutely burned, or when skin is subjected to electric shock. And slow pain mostly occurs when there is a damage to the deeper tissues or organs, like organs in abdominal pain, then muscle spasm, etc, etc. So the deeper pain mostly is of slower type. Okay, now we will continue discussing differences between fast and slow pain. As we have discussed previously, that pain can be elicited by three types of stimuli, either mechanical, thermal or chemical. Out of these three, only mechanical and thermal can elicit fast pain, not chemical. And slow pain can be elicited by mostly chemical, but it also can be elicited by mechanical or thermal stimuli. So slow pain will be elicited by mostly chemical, but also can be mechanical or thermal, while fast pain will be elicited mainly by the mechanical or thermal. Now previously we have discussed about the classification of the nerve fibers, which is based on the diameter. You can classify in three parts: A, B and C. A further subtypes: A alpha, beta, gamma and delta. Now the fibers which will transmit the fast pain signals in the peripheral nerves to the spinal cord will be of A delta types of fibers, while in case of slow pain those will be C types of fibers, which are slightly thinner as compared to A delta types of fibers. Now the velocity of the transmission will be 6 to 30 meter per second in case of A delta types of fibers, and 0.5 to 2 meter per second in case of C types of fiber, which is very slower. That's why it is slow pain as compared to fast. Now the neurotransmitter which will be released at the end of these nerve fibers will be glutamate in case of fast pain, and it will be substance P or glutamate in case of slow pain. So slow pain fibers will release either of these two, substance P or glutamate, while the fast pain fibers will release just a glutamate. Okay, now localization means pinpointing a part of a body from which this pain is occurring, which is nearly exact in case of fast pain fibers. As you have noticed, but in case of slow pain this localization is very poor. So when you just needle in your skin you can localize this perfectly, but in case of slow pain like abdominal pain, this localization of pain is very poor. Okay, after differences between types of pain, let's discuss pathway for the pain. As we learned previously, there are two pathways which are responsible for the transmission of general senses. Dorsal column pathway, which we have already discussed, and second is anterolateral pathway, which will transmit mainly pain and temperature. So we'll now learn about the anterolateral pathway. But pathway for the fast and slow pain are slightly different. Both will be transmitted via anterolateral pathway, but still there are some differences between the pathway for the fast pain and slow pain. Pathway for the fast pain is known as neospinothalamic tract. Because it is neo in evolution, it is known as neospinothalamic tract. And the pathway for the slow pain is known as paleospinothalamic tract. Because it is older in evolution, it is known as paleospinothalamic tract. So let's discuss first of all neospinothalamic tract, which is for the fast pain. Now the nerve fibers which are responsible for the transmission of this fast pain are of A delta types, and which will release glutamate as a neurotransmitter at their endings, will mainly transmit mechanical and acute thermal pain. Now after these peripheral nerves which just carrying the signals of this fast pain will receive the signal from the peripheral pain receptors, will enter the spinal cord. After entering the spinal cord, they will terminate mainly in the lamina 1 of the dorsal horns of the spinal cord. There they will terminate and they will excite the second order neurons of the neospinothalamic tract. This will give rise to the long fibers that will cross immediately to the opposite side of the cord through the anterior commissure and then turn upwards and passing to the brain in the anterolateral columns. Now this fiber mainly will terminate over the ventrobasal complex of the thalamus, but few fibers may terminate over the reticular areas of the brainstem and posterior nucleus of the thalamus. Now the fibers which are terminating in the ventrobasal complex are accompanied by the dorsal column medial lemniscus tract for the which are for the tactile sensation. That's why the localization is very exact in this case, that we will discuss later on. Now from these thalamic areas the signals will be transmitted to the other basal areas of the brain as well as to the somatosensory cortex. Okay, so now about the localization is very exact in case of fast pain. That is because when these pain receptors are stimulated, along with that tactile receptors are also stimulated, which will be transmitted via dorsal column medial lemniscus pathway. So when this excitation of the tactile receptors also occurs simultaneously, the localization will be nearly exact. However, when only pain receptors are stimulated without simultaneous stimulation of the tactile receptor, even fast pain is poorly localized. Okay, so localization is very exact in case of fast pain, mostly because of the simultaneous stimulation of the tactile receptors. Okay, next is paleospinothalamic tract, which is much older system, and it will transmit mainly slow chronic type of pain via C types of fibers, and these fibers will release substance P as a neurotransmitter and sometimes glutamate as well, but mainly substance P. Now these nerve fibers first of all will transmit the signal from the peripheral pain receptors via peripheral nerves and will enter into the spinal cord. Now in this pathway the peripheral fibers terminate in the spinal cord almost entirely in lamina 2 and 3 of the dorsal horns instead of lamina 1, which was the case of fast pain fibers. Here they will terminate over the lamina 2 and 3, which are collectively known as substantia gelatinosa. Now most of the signal then pass through one or more additional short fibers neurons within the dorsal horn themselves before entering mainly in the lamina 5 in the dorsal horn. Now here the last neurons in this series give rise to the long axon that mostly join the fibers from the fast pain pathway, passing first through the anterior commissure to the opposite side of the cord and then upwards in the brain in interlateral system. Now they cross to the opposite side and will end mostly in three regions. One is the reticular nuclei of the medulla, pons and mesencephalon. Second, tactile area of the mesencephalon deep to the superior and inferior colliculi. And third, they may end in periaqueductal gray region surrounding the aqueduct of Sylvius. These are the lower region of the brain, appear to be important for feeling the suffering types of pain. Okay, so these are the lower areas in which these neurons will end. Now from the brainstem brain areas, multiple short fiber neurons relay the pain signal upwards into intralaminar and ventrolateral nuclei of the thalamus and into certain portion of the hypothalamus and other basal region of the brain. So that is the last stop for this paleo-spinothalamic pathway. Now localization is very poor in this paleo-spinothalamic pathway because no simultaneous stimulation of the tactile receptors, which are very sparse in deep region, and the slow pain is mainly from the deep region. That's why localization is slightly poor in these slow types of pain. Okay, after discussing pathways, now let's discuss some other types of pain. One is referred pain. You have heard about this. Often person feels the pain in a part of body that is fairly remote from the tissue causing the pain. This is called referred pain. For example, sometimes the patients of heart may feel pain in shoulder. So knowledge of these different types of referred pain is important in clinical diagnosis, because in many various ailments the only clinical sign is referred pain. Now how it occurs? Let's see one figure for that. Now as you can see, the visceral pain fibers, which is demarcated as a 1, will receive the pain fibers from the viscera, and the pain fibers from the skin, which is demarcated as a 2, will receive pain fibers from skin. Now both lie just besides one another. So sometimes what happens, the pain fibers from the viscera will just spread these signals to some skin nerve fibers. So person may feel that the pain from the heart is coming from the shoulder, so mix up will occur. So that's how the pain of heart will refer to the shoulders. So that is mechanism for the referred pain. Now other type, that is visceral pain. Now visceral pain is a simple pain from the viscera. Now often viscera have sensory receptors for no other modalities of sensation besides pain, means touch and other sensations will not be present in viscera, only pain receptors are there, and they are also very sparse, means very less. So only diffuse pain will occur, that is slow type of pain will occur. Now some mechanisms, some causes are there for the visceral pain, as we have discussed: ischemia, chemical stimuli like acidic metabolic end products, acidic gastric juices, so acidity, then spasm of this hollow viscus may cause pain like muscle spasm, then over distension of this hollow viscus may cause pain, same as muscle spasm. These are the various causes of the visceral pain, which is slow type of pain and diffuse pain. Now another type is parietal pain, which is actually caused by the viscera. When disease affects the viscus, a disease process often spreads to the parietal peritoneum, pleura or pericardium, which is covering of this viscera. Now these parietal surfaces, like the skin, are supplied with extensive pain innervation from the peripheral spinal nerves, which is not the case for the viscus. Viscus contains very less numbers of pain receptors, but these parietal surfaces have extensive pain innervation. So when pain of the viscus will spread to this parietal wall, then this pain, very frequently sharp pain, will occur overlying the viscus. An example can emphasize the difference between this pain and true visceral pain. A knife incision through the parietal peritoneum is very painful, whereas a similar cut through the visceral peritoneum or through a gut wall is not very painful, or if painful at all. So this parietal pain is very sharp and acute, while the visceral pain is slow and diffuse. Okay, so that is enough for the first part. Still, pain is not over, so we'll continue discussing the pain in the second part as well. In the second part, we'll discuss pain suppression system, that is analgesia, and applied aspect of the pain. Okay, so thank you.